bit. If I can work out, bear with me a second, how to, how do I add it to the,
that was, see what's in the arrow.
That's all that's coming up from there.
Okay.
Sorry.
Yeah, it should be there.
Oh, no.
Okay, I think we're failing at the first hurdle.
That's just sending it under the empty method.
What I might do is Anjaly will start, and I might see if I can send it as a Word document to you, Jenny, and that throws that onto you. I know, but if that, I don't know, just a different person having a go whilst we start, and if it gets in the chat, that's brilliant, and if it doesn't, we'll keep going. Should we try that?
Yeah, absolutely. That's great. Thank you very much, everyone, for joining us for this show and tell. We're going to talk a little bit about our innovative approach adopted by Brunel Medical School, looking at a new module combining psychology, sociology and lifestyle medicine taught with a team-based learning format. My name's Dr. Anjaly Mirchandani. I'm a senior clinical lecturer at Brunel Medical School and module lead for this PSLM module. I also work as a GP with an interest in lifestyle medicine.
And hello again, my name's Jean Potter. I'm a consultant in palliative care at the Hillingdon Hospital, which is what the vast majority of my working life is spent doing that. But I'm also a senior lecturer here at the medical school and have a degree in sociology. Over to Survjit.
Hi everybody, thanks for coming. My name's Dr. Survjit Cheeta. I'm a reader in psychology, so I've been responsible for the psychology content of the module, but more so working both with Jean and Anjaly to ensure that the psychology content is well integrated with both the sociology content and the lifestyle medicine content.
Great. Thank you. So just giving you a little bit of a background as to why we're doing what we're doing and the context and rationale for our module. So we know that non-communicable diseases, long-term diseases, are increasing worldwide, and alongside that, health inequalities appear to be worsening. We attended a recent Association of Medical Education conference where one of the keynote lectures discussed the importance of education with relation to health inequalities, but also thinking about empowering our students to think about what they can do about these from there. So therefore, we feel that educating medical students about the biopsychosocial model and empowering them to partner with their patients they're treating to improve their health and their health outcomes is now crucial. I'm probably preaching to the converted here, but as many of you probably feel, teaching of sociology and psychology has often been marginalised in undergraduate medical training with sort of little time given to it, but hopefully that is increasing. Teaching of the newer discipline of lifestyle medicine, however, has been largely non-existent. Yet these disciplines are crucial for understanding patients' lives, their experiences, and helping address their health outcomes in a holistic manner. And given this challenge, it's really important we look at, a new contemporary perspective in medical education. So we work at Brunel Medical School, which is a new medical school with our first cohort started in 2022. As part of the curriculum development, this module was developed, so combining psychology, sociology and lifestyle medicine within one module. Our entire module was taught using team-based learning, which we'll describe a little bit more later on. And that's an important part of the pedagogy at Brunel Medical School, particularly in phase 1, so years 1 and 2. Literature on the use of TBL report its use in medical education, looking at the sort of biological and scientific aspects of medical education. It's also been reported to be used in psychology teaching, but not so much in sociology and lifestyle medicine. So this is a new innovation. It encourages students, this module, we hope, to build their medical expertise alongside this person-centred mindset and recognising the importance of these 3 disciplines as part of that as well. And we ensured that equality, diversity, inclusion were embedded into the curriculum. To help inform our module and make sure we incorporated important principles of all three disciplines, we looked at each of them separately. So to inform our psychology content, we looked at the GMC Outcomes for Graduates 2018. We also looked at the best core curriculum for psychology and undergraduate medical education, as well as the textbook pictured here, Psychology and Sociology Applied to Medicine, which we used as a key text throughout and which our students also have access to. The sociology content was also similarly informed using the GMC Outcomes for Graduates, some relevant contemporary textbooks, and also the best core curriculum for sociology and medical education. With lifestyle medicine, we had less to go by in terms of recognised curriculums from the UK at the time we first started developing this. And though the GMC Outcomes for Graduates does now talk more about ensuring we discuss well-being and long-term conditions and things like that, so we use that as part of it. We use some relevant textbooks as well as guidance provided by the American College of Lifestyle Medicine and the British Society of Lifestyle Medicine. Just to make sure everyone's aware, so lifestyle medicine is an approach to healthcare which focuses on preventing and managing non-communicable chronic diseases, so long-term conditions, by trying to address more of the root causes of these illnesses, often related to lifestyle choices and circumstances. Putting all three things together links us with the biopsychosocial model, and we developed these overarching module level learning outcomes for this entire 2-year longitudinal module. As on the screen, the first to equip students with knowledge and skills in all three disciplines to enhance the care of oneself, the patient and society. And learning outcome 2 to integrate all three disciplines of health, illness and disease and explore how these impact on patient experiences and outcomes. I'll now hand over to Jean to talk a little bit more about how we did this.
So thanks ever so, Anjaly. So my part of the slides is to go through these 4 points of how we went about creating this module and delivering it. So first of all, yeah, we have moved on. Sorry, it's a bit thrown there. Like all good educators, we start with what are our learning outcomes and making sure that they're constructively aligned. And as Anjaly has talked about the resources, what we were trying really hard to do together was to triangulate those resources. So the three disciplines of psychology, sociology and lifestyle medicine were interwoven into every learning outcome, as opposed to having, this is a bit about psychology, this is a bit about sociology, and this is about lifestyle medicine. So you could see that the beauty and the strength of joining all of those disciplines together, they're all bigger than the sum of their parts. On this slide and in subsequent slides, I've just chosen one of the sessions that we gave, which is called Empowering the People Nutrition. We're showing you the session and intended learning outcomes, which hopefully show that where we were able to make sure that those disciplines were aligned. And so the next slide, that just shows you the titles of the 10 sessions that we made all together. And I think the important bit that kind of when we made the slide and in terms of discussion, we realised that we were making 2 sub-themes, which we didn't really set out to do, but we realised that was what was happening. One which is about development of the person and one about empowering people. So in terms of development of the person, what we were trying to think about is what are the biopsychosocial influences that make us who we are? And how do those influences influence our experience of health and healthcare? And then we all experience health and healthcare as individuals, but how can we also look at those influences to see how we can best practice medicine as we qualify and start to care for people and our functioning doctors? The next bit was, if we understand all of those things, how do we move from understanding the psychological, social elements, etc., and understand that we live in an unequal society and that the major worldwide cause of ill health is long-term conditions? How do we use that knowledge and do something about it as doctors? And that's where lifestyle medicine comes in, and hence helping people to empower themselves. So that's our learning outcomes set out. And usually the next move would have been for us to discuss and decide what method of teaching and assessment we want to use. But as Anjaly has said, that was set out for us, and it is TBL. So there's not much known about using TBL in this setting. There, in 2014, there was a systematic narrative review of 40 studies, and of those studies, 24 of the 40 were on healthcare courses, but none of them specifically on psychology, sociology, or lifestyle medicine. Also, we were starting from a place of little or no, in my case, experiencing of delivering TBL. And so it's really helpful now that we have, as Anjaly says, done it 1.5 times, to be able to talk it through with you and see how it lands with you and what your thoughts are about it. So I don't know. Oh, sorry, I should have moved on. So that was something related to development of the person and empowering people, and what did we use to try and get that across to students. But I will move on quickly again, because we don't know how much of you guys know about teams-based learning, but I do want to run through this quickly because, as I say, it is the format which we are required to use. So TBL has been shown to have a positive educational outcomes in terms of knowledge acquisition, student participation and engagement, and team performance. It's overall been preferred by Brunel Medical School, and the students here do a whole day of TBL twice a week throughout their year 1 and their year 2 studies. And that's been brought on board because it's been shown to be an efficient use of resources with a high level of student engagement, which I think is really important, as the idea is that the number of medical school places is supposed to increase as we try to produce more doctors. So it's large groups together undertaking small group exercises, because we have the whole cohort together, but they sit in tables of 6 and do all the tasks as their tables of 6. So TBL is a very, very specific process. And BMS were very committed to delivering each element without deviation. So we have to do all of these things. The first part is they get pre-lesson work, which is the form of pre-recorded lectures, which are available to students remotely 2 weeks before the live session. Then when they come into the live session, the very first thing they do is they do something called the individual readiness assurance tests, which is basically a single best answers multiple choice questions. They answer that in test conditions, and then they moved on to team-based readiness assurance tests, which are the same questions again, but thrashed out as their group of 6. And then you finally move on to application exercises, which is problem solving and clinical skills practiced through structured exercises. So I'll just move that on, because what we'll show you then is how did we use that model, which we were not allowed to deviate from, to the best of our ability. So each half-day TBL has 15 multiple choice questions within it. So we use them to check core concepts are understood. It's part of the TBL process, 15 multiple choice questions. So it's 150 multiple choice questions that we had to use for the whole module and create de novo. And I remember being on a best show and tell where we were thrashing out how to make multiple choice questions. So I'm sure you're aware that actually they are quite hard to make good ones. On top of this, we've had to create SPAs for the termly AKTs. And the content of the AKT is weighted across the curriculum. So each paper doesn't only had a handful of PSLM questions, but it did mean that we had to create 150 plus questions. Just to point out that that photos doesn't come out brilliantly, but what it's trying to show you is how big the room is, how many students we have together, and the fact that they're sitting in their TBL tables. So briefly, this is an example, because again, we were just going to look at nutrition over and over. On the left-hand side, you've got an example of an SPA that we wrote. On the right-hand side, you can see the TBL specific software, which is called LAMS. And that shows us in real time, while they're actually doing it, how students are individually in their IRAT and afterwards as their TMATs, how they're performing. Are they getting the questions right? Are they not getting it right? So the IRAT is part of the summative assessment, which goes towards their final mark, obviously, and the TRAT is for thrashing out as a TBL group what the correct answer is. And if they can't work it out themselves, then we can see that on LAMS, and then as content experts, we can then get to the bottom of the ones that they're finding particularly difficult. So
Claire, are you?
higher level thinking being developed, that's what the application exercise is supposed to do. It allows for areas to be looked at in more depth or interrogated more closely. AEs are often case scenarios with various task sets, and again the very specific TBL process is that we have to use the forest approach. So all TBL's groups address the same problem or case scenario. The scenario must have clinical significance and therefore is often person-centred scenario. Various solutions are given within the task. What are the possible answers? But it's still in an MCQ format, so specific choice. And LAMS reports in real time, as shown on the right, with a simultaneous report can show us how TBL groups are engaging and performing. Then TBL groups can make different choices and they can discuss with each other why they made different choices. And this does not project brilliantly, but sorry, go back here. So you look on the right hand side. For example, there's two copies in this. Yeah. So sorry, bear with me. We will use this next slide. So this is an example of an AE, and what we've done for the benefit of getting it onto the slide is the case scenario has been abbreviated, but it has biopsychosocial aspects for it, and the students are given tasks. You can see the tasks here. That's related to what they've learned in the pre-session teaching material by applying it to real world scenarios like you can see here. So then if I do move on, hopefully this will make some sense. Sorry, I'm rushing a little because I've got quite a lot to hand over to you, and then we want to hand back. We want to hear from you what you think. So for example, in this first task, they were asked to give which factors might be contributing to the development of this person's obesity, give examples of each category and justify your answers. This does not present very well, but you can see on the left-hand side that we've suggested that there might be behavioural, psychological, sociological, environmental elements to it. And I can tell you, because you probably can't read it. So, for example, table 2 made different choices to table 1. So once they've actually done the tasks, then what we might do is bring all the tables together and say, table 2, explain why you chose this. And table 1, tell me why you chose that. And can we get even more consensus there together? So that's kind of how the TBL works. We also have outside the TBL session, we have the opportunity for them to encounter the importance of the biopsychosocial model elsewhere in the curriculum, including in their OSCEs. So very briefly, this example shows how this OSCE scenario requires them to identify lifestyle medicine pillars, and it requires them to use related interventions. And if they do that, they will get awarded marks in their OSCE mark scheme. So they're motivated because hopefully you can see that it's important clinically. They're also motivated because this is another way it goes towards their summative assessment. So in a nutshell, that's how we've been doing it. I'm going to go over to Anjaly and then Survjit to talk about the strengths and the weaknesses of the approach and how we've developed it since our first iteration.
Thanks, Jean. So obviously we've now run this module for 1.5 cycles, and over the course of this, it's important, we've recognised it's important to evaluate it. So we've noticed some strengths of our approach. So PSLM, co-designed and delivered by a content expert in each of these 3 different subject areas. So this provided good input for each of the 3 disciplines and a fertile ground for exchange of ideas. All of our session level learning outcomes combined the 3 disciplines, as Jean mentioned, so they're not chunked up, but so that students can see how it's all joined together and the relevance of them. We emphasise the biopsychosocial model and recognise themes for development of the person and empowerment of people. We also ensured that we had alignment with other areas of the medical school curriculum. An example is the clinical communication skills, where students, as seen in the OSCE station, are taught about the importance of recognising and acting on lifestyle factors and lifestyle pillars, as well as things like readiness for change and the stages of change model. Key concepts that we teach are revisited within the Spiral curriculum as part of the MBBS programme, and their skills are practiced and demonstrated, for example, in communication skills. TBL has cost and resource implications. So creation of each of these TBL sessions requires significant preparation time to develop the pre-session work, pre-recorded lectures, multiple choice questions for the IRATs and the application exercises. These are also quality assured and reviewed each year, so this takes a significant time. As from the photo shown by Jean, we need a suitable team-centric learning space to house all of the TBL sessions that allows the students. Our current cohort has 150 students and the capacity of our room is 160 students. So this is something we're going to need to think about in the future, and we need big rooms for this. E-learning systems are also really important to facilitate all phases of the TBL process. So we use Panopto pre-recorded lectures, stored on Brightspace, which is our university learning management system. The actual TBL process, the software we use is something called LAMS. So all of these systems are important. I will say, however, that it is possible to run TBL sessions using scratch cards and things like that. It doesn't necessarily require the electronic learning management software from there. It also requires resources of groups of people. So each of our sessions has us as content experts, as well as TBL facilitators to help deliver and run these sessions. TBL as a concept was new to our students, but also new to a lot of our staff and faculty. So training was required to develop this. So there are significant resource implications with what we do. However, initial evaluations of our module have been promising. In class, students often reflect on their own lived experiences, and we do bring out rich discussions, particularly during the application exercises. And qualitative feedback received so far has been excellent. An example of which from one of our Year 1 MBBS students was this. So feedback such as this reinforces the need for this sort of holistic, inclusive approach in medical education, and hopefully confirms that this PSLM module is making a positive difference in the student experience recognised by our students. But we continue to reflect and review our module, and one of the questions we keep returning to was whether that TBL single best answer format was the optimal approach for the content and the concepts that we're trying to teach our students from there, particularly when we think about higher level learning and things like the application exercises. And TBL currently is very MCQ heavy, they have their benefits, but also we deal with sort of complex social phenomena, theories, methodologies, and actually we wondered about using other approaches. We are limited within the medical school to TBL as a concept. However, the newest iteration of the software we use, LAMS, now incorporates AI assistance within the application exercises. So this therefore allows them to retain that 4S approach described by Jean, required for application exercises in TBLs, but allows teams to put in free text responses rather than being limited to simply the sort of artificial MCQ format as previously used. So we ran our first session using this new format application exercise just Thursday last week. So this is all very new to us as well too. This is the scenario that we developed. That, apologies, I was trying to share on the chat as well too. Students were provided with this scenario and were then required to complete 2 tasks. So we'll give you a minute to read the scenario and then Survjit will talk through our AE session a little bit more.
Okay, hopefully, thanks, Anjaly. Hopefully you've got, been able to quickly, briefly read the scenario. We've incorporated the biopsychosocial model. So there's biological aspects, there's multiple morbidities, there's social aspects, there's lifestyle aspects, and there's psychological aspects. So we were the first within the medical school, the first kind of module that's tried to incorporate artificial intelligence within our module, and particularly within the application exercises, because it allows for, you know, free text answers where students can really develop, you know, kind of their thinking skills, etc. So we had 2 tasks. First, the students were shown the scenario, and then there were 2 tasks. The first task, we focused on students identifying the health inequalities within the scenario situation. All students were given 3 resources on the left in order to undertake the task. So they couldn't use the internet at all. We provided them with the resources that we wanted them to use, because we didn't want them just to enter, you know, the question into ChatGPT or something. We wanted them to actually read things and think about things. Then for each task, there was learning outcomes. The way we did this was we developed our own learning outcomes, but with AI in LAMS, when you enter the scenario into LAMS, it will produce its own learning outcomes. So we had learning outcomes from LAMS and we had our own. We had a good look at them and we agreed between us what we wanted the key learning outcomes to be. And these were the 4 learning outcomes that we wanted students to address. So look at ethnic health disparities, look at mental health challenges, impact of social isolation, and also prevalence and the impact of smoking and alcohol use, particularly within an ethnic minority population. So what does AI produce for us when the students do the exercise? Firstly, what you see, I'm so sorry this is so small, what you have is the number of TBL teams or tables, which are down the left-hand side. So we had 19 TBL teams, and then across the top, you've got the 4 learning outcomes that they were being assessed on for this particular task. The minimum score they could get was 1 and the maximum score was 5. And what we found was generally that the students did, you know, exceptionally well. Most students got a 4 out of 5 on most of the learning outcomes for this task. So what else do you get? In order to get this summary, what the students do is they can write in a free text box, and all students can, you know, if one student writes something, for example, another student can edit it, add some more. So here I'm really well, I think we're all sorry this is so small, but it shows you for task 1 of the 4 learning outcomes, the sort of things the students talked about. And given how well the students did, they really did cover, you know, some of the major issues that were relevant to that learning outcomes. What the AI also does, actually, it tells each group what were the highlights of their, you know, of their submitted answer, what areas there for improvement. Obviously, you know, this needs a bit of a human check to make sure that, you know, we agree with what AI is generated. So then we had a second task here, and really clinically relevant to the students. We wanted them to develop a holistic person-centred care plan based on the case study. We presented them with clear justification of why they chose the actions that they did. Again, we provided them with a list of relevant resources. Here, we particularly relied on NICE guidelines for diabetes, chronic physical health conditions, and some of the other conditions that Imran presented with. And again, we agreed, we had 5 learning outcomes. Some we took from AI, some that we'd come up with ourselves, and they're on the right-hand side. Again, what you first get is a summary of how well the groups did across each of the learning outcomes. And again, generally students did rather well. We had some sort of 3 scores, but again, most groups getting 4 out of 5. And we can see on when the students are doing the tasks. You can see on the LAM software whether all of them are engaging with the task, because you can see who's editing the free text box, and we had really good engagement from all of the students as well, and that means they bring in their different ideas. Again, an example answer. So the free text answer the students gave to each of the learning outcomes. And again, AI shows you what the highlights were and what areas for improvement. So that's useful feedback we can give to the students, but obviously we do need to look at it and ensure that, we concur with the feedback. So what was the feedback? Before we ran the session with the medical students, we actually did a pilot with our medical education fellows. They all preferred the new format, and some of the feedback that MEFs gave was that the blank page encourages engagement and promotes collaboration. And we certainly saw that actually last Thursday when we did the session. We found that the free text allows students to bring in knowledge from other modules or elsewhere that they couldn't use in the TBL, that they couldn't use if we used a single best answer approach to the application exercises. So they could bring in, material that they might have learned about diabetes, even things they might know from family members, etc. Because we limited the availability of resources, the students simply couldn't, put the, task into ChatGPT and produce an answer for us. And it required students to also develop their kind of academic skills in critically analysing key relevant clinical resources. So what did the medical students say? Just some good feedback and some feedback for us to think about and take forward. So a few of them really enjoyed the session. They found it really engaging, and they found that every member in their team was participating, which is the aim of team-based learning. The students liked the nature of the exercise. This is the first time an AE, kind of an open free text AE had been used, with the students having to also read a few resources, or at least, skimmed through a few resources, and for some of the students they found it a bit too much and found the reading a little bit too much. But I certainly think in our experience as a team, we felt it really, we really enjoyed delivering the AE in this format, and actually, as well as covering the learning outcomes, a lot more came out of the discussion. We talked about, yes, the students were asked to develop a holistic care plan, but what would be some of the real life limitations in terms of the NHS resources? They came up with ideas that we absolutely didn't think about. In the case of Imran, for example, he could develop new social connections, including possibly finding a new partner. So it was really quite an enjoyable experience. And I think it really helped the students to think about what they would do in a real life situation where patients do present with multiple morbidities and a number of social, psychological and lifestyle issues. So in terms of future directions, we would really like to do further AI AEs, and I think it was really useful in terms of not only the free text, but helping generate very specific learning outcomes, actually. We did get some feedback from the students that, they found it a bit too much. So what we certainly would like to do is perhaps, get the students to maybe co-create some of the future AI AEs with us, take their feedback and perhaps try them out on next year's students. Brunel's first cohort of medical students have just entered phase 2 of the curriculum. So they've just gone out onto their, clinical placements. So we really want to include more PSLM within the phase 2 curriculum. And we think that with students coming back from, actual real life experience of patients, they might really start seeing how incredibly useful it is, looking at, as well as the biomedical side, looking at psychological, sociological and lifestyle medicine factors. And the other thing we're really keen to do is within the more, scientific-based modules that students do include some PSLM. So again, they really adopt a holistic approach to treating patients and being the future of the NHS. I think these are some of the references that both Anjaly and Jean referred to, and we want to acknowledge key members of Brunel Medical School here, and we'd like anyone to contact us if they'd like. And certainly from our perspective, and certainly from my perspective, this is the first time I've had to develop a psychology curriculum for a medical school. So anybody who does psychology, really welcome. I'm sure the other two would feel the same. Yeah. So but we really want your feedback and questions more than anything.
Thank you.
Thank you so much.
Thank you so much. That was so interesting, and I appreciate you leaving time for questions as well. Apologies we couldn't get that file added up onto the into the chat, but I think everyone got the idea anyway. So if we open it up now for questions, does anyone want to raise their hand to ask a question?
We'd also love just feedback in general of what you all thought about this and how we can develop it further.
Yeah, question, comment, anything like that. We've got Vary.
Hi everyone. Firstly, just wanted to say thank you very much. It was a fascinating presentation. I feel like I'm meeting colleagues, and I should have been doing this many months ago or years ago, just hearing all the issues that you faced, how we communicate the importance of this learning to medical students. So it was amazing. I had a problem with the audio at one point at the beginning, so I apologise if you said this and I missed it, but a really interesting thing you commented on was the resources didn't allow students to kind of jump onto ChatGPT or similar. Was that just a mechanical feature of the software, or how did that work?
So for the students, for them doing the IRATs and the TRATs, they have lockdown iPads, university provided iPads for that particular part of it to stop them looking at other things, because the IRATs is part of their summative assessment. So on this occasion, we embedded the learning resources within that, so they could only look at the documents we provided, and those iPads don't allow other internet access. It doesn't have a browser on it. So that's how we limited it from there.
That's really helpful.
And that's put their phones away.
Yeah, I was just going to say, but I guess in a way, even if they are engaging with those materials, they're still working as a group. But it's great that you managed to pull it off in that way. I guess the other thing that you said really struck me. One of the issues we always have is whenever we try to be creative about some of the things, we've got 450 medical students each year, and some of the practical barriers. But it's just we just have to overcome these things and not see them as a complete barrier, just something to work around and be clever about. And I really love the idea, if I understood it correctly, that the students are inputting free text, but the joy of some of this software is it's pulling out some of that content. And even with a human check, I know sometimes people will shy away from initiatives because we just think about the burden it's going to add to marking, but that sounds amazing. I'd love to know more about it, and thank you.
I think just to add, so when I guess that we've learned a bit about the AI bit of it, but we've been doing this for a couple of years now. So the first bit is summative. So we had to shut down their iPads so that had already happened. We had already realised that was the case. When we did the AI thing, when we looked to see if we made the scenario up, we put it into AI, we were gobsmacked about how good AI was giving a result, really, really good. And we really didn't want them to just simply do that and then just put it in. To be fair, the software can tell if you're typing or you are cutting and pasting, but we just wanted to cut them off at the pass because we thought some people will just definitely do that and then sit back and wait for the next task to come. So we've been learning bits about how to do this, and then the AI is a whole new bit.
Thank you. It's really, really very good work. Really interesting. Thank you.
Thanks. Great question. So Penny Gear on the screen, and then we've got another Penny List that's asked a question in the chat, but over to Penny Gear first.
Hi. Yeah, I've been using TBL just for a year, but mainly to teach actually public health to year ones. We don't have the nice software, so we have been using the scratch cards. And in the first year, I was doing the IRATs with a pen and paper, which was a bit of a nightmare. So this year we're using Microsoft Forms, which is a bit better, but we're not using it at the moment as a formal assessment strategy. But it is something we're considering using next year. So I was interested about your comment, because I was going to ask how you managed it, but the lockdown iPads makes quite a lot of sense. I hadn't come across the LAM software before, because when I did my training, it was with Interdashboard, who are another sort of like big company that do it. So I think their software's different. I guess my question is, one of my questions was, how many facilitators do you actually have in the session? Because at the moment we've got 200 students in the year, so what I tend to do is run the session twice, but there's literally me and the subject expert. So and it's in a lecture theatre as well, because that's the only room we've got. So it's been interesting to try and to do it in that way. How many facilitators do you have on the day? Do you have a lot more facilitators to go around and actually be able to interact with the tables?
We usually have one. Because we were piloting this time, we had a bonus one and someone else there for part of the session too. But usually we just have the one facilitator and the content experts available there.
Okay.
And just to go back to some of the things that you were talking about, so yes, we have the electronic system, which was bought because the medical school bought it and we have to learn it. We have a significant number of students who have reasonable adjustments, so they will do the IRAT in a different room because it is summative for them. We had one student who the lift broke and she'd broken her ankle and she couldn't actually get into the room, so we quickly photocopy one for her so that she could do it downstairs in a different place. So it's not without its interesting moments doing all of that. I do feel for you in a lecture theatre, because I think they need to sit in groups and do it. But, you know, again, it's about the physical space that you have and how that interacts with the teaching that you're trying to give is tricky.
Yeah, so the first couple of times we did it in the lecture theatre, it was a bit difficult because the students tended to sit in a long line, and we've now got to the point where there's a seating plan, so they're at least in the groups are like one in front of the other, so that they can at least turn around and talk. But yeah, it's not ideal, but there isn't a room anywhere in the medical school, I don't think, that's big enough. So yeah.
So this is, we're limited by this room, so if when we get any bigger, it also limits our kind of IPL opportunities, which is what we'd really hope to do, just because there isn't a bigger space to put people in.
Thank you.
Thanks. So can I ask you to consider or to answer Penny's question in the chat, which is about are psychology and sociology taught elsewhere in the curriculum?
I teach psychology as part in some of the modules, like in, for example, when they're taught about pain, I cover psychological aspects of pain, placebo, nocebo effects, but it's something that actually we want to, that's kind of one of our plans, to try and integrate psychological and sociological aspects in other parts of the curriculum, particularly when discuss chronic conditions. Anjaly, do you want to touch on that? Or
If you go, I'll go.
Yeah, absolutely. So at the moment it isn't, or doesn't feel like it's incorporated into a lot of areas, but we're hoping to increase it, and particularly as the phase 2 curriculum is continually being developed, there might be spaces to put it in there.
And the other thing I would say is that there is overlap, I'm sure, as you have too, with medical humanities. So, for example, one of the medical humanities sessions is about death and dying, and that the sociological aspects is drawn out in that. The students get an opportunity to do a self-selected component at the end of year 2, and we are in its infancy with creating projects for that. This last year, Survjit had some psychology ones. We've got aspirations to do more of that. And there are elements, because it fits with primary care. So some of the blogs that they have to do and some of the projects they have to do in primary care will overlap with us. But as sort of prime time stuff, it's this session.
Thanks, that's really useful. If nobody else is jumping in at the moment, I'll be cheeky and ask a question. Oh, Georgina, too late. I've started, so I'm going to carry on. I'm sure we've got plenty of time. So I guess I don't know how well I'm going to formulate this as a question, but I'm a sociologist. So as a sociologist, I feel uncomfortable with the term lifestyle medicine. And we have, as a sociologist as a discipline, have a very critical perspective. So that's core to it. And I'm really wary, and I know that the people teaching in that sort of area within our year one in particular are very cautious about reinforcing discourses of individual responsibility and neglecting the structural factors that underpin all of those choices that people are making. So it's not to deny that what you're encompassing within lifestyle is significant and impactful on people's health. But I'm very, very cautious of that. So I kind of wondered about how you manage that and how you manage the tensions that exist between the disciplinary approaches. So psychology would view these subjects potentially in quite a different way than sociology would, and then lifestyle medicine sits somewhere potentially in between, but I would probably position it a bit more towards the psychology. But how you kind of manage those potential tensions and the risks of reinforcing, I would guess, something that you're not intending to reinforce around individual responsibility. Or maybe you are, and maybe that's also me assuming that you're not. Maybe that is the core message you want to get across. So I backtrack slightly and say it would be a concern for me.
The worry about lifestyle medicine and how we sort of interlink.
Yeah.
So Anjaly, first of all, because she's our lifestyle medicine go-to.
So I think absolutely, and I think that's one of the big criticisms of lifestyle medicine as this new discipline is, right, you're making these choices and that's the only reason. But I think we've tried to make a real effort to step well away from that, and that's where the richness of integrating with the other disciplines has come from. So an example, when we talk about physical activity, we talk about actually that involves societal planning and people not having the spaces and those things. So recognizing those limitations so that it's not individual responsibility, and we, talk about what we can do in the constraints of the other parts of it, I think. So trying very hard to move away from that. And hopefully even with lifestyle medicine, which particularly in this country is growing. So from when we started, there are about 2 or 3 main textbooks. There's now 5 or 6 out there. Even the British Society of Lifestyle Medicine, if you look at their kind of main sort of manifesto and things like that, has moved away from just these are the 6 pillars and people need to make these choices, but actually we're looking at it in the context of health inequalities and societal factors and what can we do within that. So hopefully we're moving away from just pointing our finger at people and that sort of thing.
So I would say 2 things with the banging the sociology dramas. We quite often go, we're talking about what choices might this person make, or how might you help support them in their decision making, and then I'll be going, is it a choice though? Have they got a choice really? And so that hopefully we've only shown you a tiny bit of the AEs, but what we're trying to pull out there is to say sometimes we ask questions. What choices do you think this person could make at this point? And whilst they're single best answers, we can argue it every which way. And so it's not like an MCQ as in we're all agreeing that this is the right answer. We will argue the toss about, well, you could say they were choices, but I could argue they're not choices at all. And we don't actually go, as content experts, we're saying D and E are the correct answers. We try and thrash all of that out. I think the other thing which I think lifestyle medicine is really tricky, because it's a bit like palliative care in that over the years we sometimes struggle with patients who do not want to be referred to palliative care because palliative care is a terribly frightening term and they've misunderstood what it is. I think lifestyle medicine can fall under that problem. But the reason why palliative care, when we've argued it one way or another over the years, is don't change, is that you'll only find that next time you name it, you'll come out with a similar problem or a similar prejudice. So lifestyle medicine, I don't think is a great name and talking about pillars of choices aren't great, but I still think that they're better than not doing anything at all. So that's probably where we are in that evolving idea. So
I think what I just would want to add, I mean, we cover lifestyle medicine, you know, within the context of health inequalities. Often our, you know, scenarios are ones that are, you know, people with the, you know, the poorest or with the most health inequalities. And I think hopefully what we're achieving, I don't know if we are achieving that, anybody, yes, there are structural massive inequalities and we make a big point of that, but hopefully people can be empowered with what choice they can make, and that they can, you know, we can all change our life. Yeah, you're not to blame, it's not your fault, but we can all change our lifestyle, maybe just a little bit, or within the context that we can change, make certain lifestyle choices. And I think, you know, think about like, you know, conditions like diabetes, you know, encourage things like, you know, healthy eating is a lifestyle choice, or change eating habits is a lifestyle choice that people can make, with, you know, obviously within limitations. Yeah, is it then? There you go.
Yeah, I think we could open up a massive can of worms there. I would go, is it? I'm not sure, but that's a whole different debate. But I totally get what you're saying.
I don't know, Jenny,
Maybe we move on to Georgina's question, and she has been waiting very patiently. So I think this we could go on for a long time with this. But Georgina.
Thanks, Jenny. I thought my camera had come on. I'll just add one comment in relation to the discussion that's gone on, which is I think many of us would share the concerns about the implicit messaging that some people take from the description of lifestyle medicine, but it's a train, I think, that's left the station. You know, I mean, the Royal College of General Practitioners now have an accreditation for lifestyle medicine practitioners. The British Society of Lifestyle Medicine has quite a lot of standing. It's quite well known. My experience is that there's a real appetite from students for the subject area. I had an email just last week from our lifestyle medicine champion at Dundee Medical School, who has been approached by a group of students who want to set up a student society for lifestyle medicine. So I think, yes, there are difficulties with the terminology, but it's up to us probably to be clear about the scope and where this does sit in the much bigger landscape of the social gradient of unequal health outcomes. And I think, you know, it's incumbent on things like public health to ensure that it's contextualized. So I just wanted to add that component, because I think we all recognize it's not ideal, but I don't see how we can overcome it now. I think it's, as I say, it's already become established. My question was around whether you've identified any particular accreditations that might be appropriate to be able to recognise people who want to pursue this area in more detail. So the reason I asked this question is we have got quite a lot of lifestyle medicine slowly finding its way into the curriculum. One of the things I've got two questions really. One of them is currently I'm looking at setting up potentially a lifestyle medicine year 5 SSC as an option. And if we do that, I would really like to look at some level of accreditation. So I've been looking at, for example, some of the health coaching accreditation courses, which would be potentially one of the skill sets that you would develop if you were going to take lifestyle medicine to a slightly more developed standard, because we've got assessment in years 1 to 3, but currently nothing in the clinical years 4 to 5. So I'd be interested in whether you've identified any external accreditation that might be applicable, because certainly we do that in other parts of the curriculum. You know, students who are pursuing areas of specialist interest, sometimes they're able to get, so for example, if they're doing medical education, they can get associate fellowship in HEA. So I'd be interested if you found anything like that. And the other question, and I'll probably stop there because it's 2 minutes to 4, so you haven't got time to answer 2 questions.
Yeah, I was going to say, if you could answer that Georgina's question very quickly, and then we can maybe squeeze in Eva as well.
I was going to ask is how long is the component then? How long have they got study?
Potentially 8 weeks.
Oh,
Okay.
okay.
So,
Well,
I was going to say, so quite honestly, I haven't looked at any accreditation. We're still so much in our infancy. I think all our time has been spent trying to develop this, but that's definitely food for thought and something for us to look at. Our SSCs at present tend to be 6 weeks was the present, so we don't have a lot of time for the students to develop this. I'm not sure what they're going to look like later on in the curriculum as yet, because that's still a work in progress. So, but definitely something for look at. But the short answer is we haven't as yet.
Well, so I thought you were going to talk. So Anjaly has a diploma, but obviously you're not going to do anything like that in 8 weeks.
Yeah.
I mean, what ours do is they create a poster, and there's a marking rubric to it, and that's how they pass that element. But I don't think that's quite what you're asking about.
Yeah.
So interesting question.
We have preclinical year SSCs as well, and they are shorter, and they, there's just normal assessment in there. This would be for a year 5, so it would be equivalent to choosing, to do a placement elsewhere. So I'm quite interested in the because this is clearly going to be a future career opportunity for some medical professionals.
Okay. I think if we can just maybe go slightly over the 4 o'clock, we could probably squeeze in one more question. Eva's been waiting very patiently, so one more question from Eva, and then we'll wrap up.
But it's so unfortunate I have a 2-part question. I could ask a 3 or 4-part, but the first one is, both of them are building on what has been said before. So I wanted to know whether do you deliver lectures in sociology and psychology and lifestyle medicine, equipping students with theories, models, new kinds of information and ways of thinking that they have not come across before? And the second part is, again, I think that the lifestyle approach became a key kind of thing here, because I was also, that made me think of whether, how do you define the role that social and behavioral sciences play in the curriculum? Because if we are saying that there is an established branch of medicine which is, has its own weight, has its own institutions, has its own career paths, which is lifestyle medicine, hence we are kind of contributing to the development of professionals working within this field, that in a way kind of undermines the role that particularly social sciences play in health education, in terms of equipping students with a critical way of engaging with hegemonic discourses, with the hegemonic institutions, which allows us to rethink conventional ways that biomedical model constructs ways of thinking about illness and disease and health. So kind of trying to create medicine for the future, trying to incorporate health equity concerns, which are not necessarily part of contemporary clinical practice, but to incorporate this through a progressive, change-oriented curriculum. In that regard, kind of engaging with a lifestyle approach in a critical way, constantly saying that it does perpetuate this idea that individuals are responsible for the circumstances that they find themselves in, and that choices versus circumstances is a huge theoretical debate, right? Because it's either one or the other, and how do we find that middle path is a different thing. But it also then paves the way to thinking about, say, decolonizing medicine as a radical contribution that social sciences can make for medicine, which is quite, can be a difficult path because it is against the convention. So again, more coming back to so kind of what is the role of the social sciences in your module?
Shall I start with that?
Yeah,
just because I think that in my wanting to be speedy about what TBL is like, so in the pre-recorded teaching sessions for a half day, so a 3.5 hour teaching session, we are allowed to give 90 minutes of context. So the pre-recorded teaching sessions are 90 minutes. For each of those sessions, we will sit and thrash out, what do I need to say about this? What do I need to say about this? What do I need to say about that? So, so those bits are chunked. And it usually works out, but not all. No, it's not fair. So sometimes it's a third each. There just needs to be for that particular bit, 30. Sometimes it's more or less. So when I do the the key inequalities of health, that's one whole thing. I almost have that entire session to myself. We are following the GMC outcomes, but we are also following the best curriculum. So we will look at methodologies, we will look at social theory of how do we understand disability, the social model of disability. We'll look at lots of different models of disability and say, what do they bring, and what's the strength and weakness of it. So I would say that is very standard sociological and psychological things, and Survjit will do the same thing. I think the thing about lifestyle medicine is I do not see this as selling this as a specialty. I see it as selling it as a method that's amongst many of them. So, for example, because I also teach comm skills, I really welcome that we say in your comm skills, when you take your history, I want you to ask feet, fingers, sleep, stress, love. I want you to ask about diet. I want you to ask about exercise. I want you to ask about social relationships. I want you to ask about loneliness. They're all those parts that we would think that was important. So I see real strength to that approach, as opposed to this is a specialism of its own right, which we're selling to you. That would be the things that I would think was important to in answer to that. But I'll let these guys go too.
Do you know what? I think your feedback's really really useful. And I think it's something we will certainly think about as a group. We very much focus, and I think all of us very much believe in a huge amount of health inequalities are structural. That's our personal position. I think we teach we teach lifestyle, not about what is your fault. But are there little ways? Are there little things you can do that can improve the quality of your life? That doesn't take away that there are big structural issues here. I think it's something
and that maybe what we'd be seeing is in some of those answers. Are you going to advocate for your patient? How will you advocate for your patient? How can you do social prescribing? What would be the things that you would think outside the box of just purely insulin is the treatment for diabetes, rather than actually there's lots of different things here, and think about all of them. Anyway, shut up again now.
But also I think a lot of our focus was, if you look at any clinical guidance, so all those 4 nice guidelines we provided our students, almost the first line is look at psychological, sociological, lifestyle factors and counsel on these. But we don't train our students to do any of that traditionally. At medical school, I wasn't really told. And so it's more giving them input on how and the importance of that, rather than go off and be a lifestyle medicine. And because there is a lot of grey around that, and it's become very trendy and very social media-y, and that's not what we're trying to do with it. We're trying to focus that part and the importance of that part in patient management. And what I think I found really reassuring is when we did this application exercise AE with the AI last week, the sort of conversations the students were coming out with, they were reflecting circumstance rather than choice. They were reflecting the complexities of the case, the aspects of actually, yes, we can talk about behavioural change, but he may not be able to do this because of that. So they have very much taken this on board, and that was really good to see that they have taken that message, rather than, well, obviously just tell them to drink less and that's the answer sort of thing. They've taken it a lot further. So hopefully they're recognising what we're trying to do with it from there.
Yeah. No, we're going to have to wrap up, but thank you so much. I think that's been really interesting. I think this will be a conversation that we can continue. So I hope you don't feel like it was critical in any way. I think it's just it's fascinating, and it's shown there's a lot of people are really interested in trying to sort of wrestle with how do we do this. It is relevant. So how do we tackle it? How do we address that? So thank you so much. Really fascinating. We'd also be very happy to have you present at the conference if you want to submit a paper for our best conference that I've managed to sneak into the chat in June, or to just keep engaging with us, because it's always great to hear how things are going. So thank you so much. I'll stop the recording now.
Thanks, Jenny. Thank you, everybody.